our second speaker here. Dr. Ronesh Sinha is author of the South Asian Health Solution. He's an internal medicine physician in Silicon Valley who works for Sutter Health's Palo Alto Medical Foundation and serves as Senior Medical Director for Corporate Health and Wellness. He's designed successful health education and wellness programs for over 16 major Silicon Valley companies, including Oracle, Genentech, Cisco, and developed a dedicated group consult practice geared to Indians and Asians with diabetes and other heart disease risk factors. His groundbreaking work in reversing diabetes in culturally diverse populations has received global attention with front cover stories in Fortune. Yeah. Fortune magazine and the LA Times, and earned him Silicon Valley Business Journal's 2013 Excellence in Healthcare Award. Dr. Sinha is a highly sought after two-time TEDx speaker, blogs actively on health at culturalhealthsolutions.com, and hosts a popular Bay Area weekly radio show on health. He is passionate about developing innovative, culturally tailored solutions to help diverse populations lead healthier lives. He'll be sharing his lifestyle plan as well as success stories on how to lose fat, increase energy, and avoid disease. Please welcome Dr. Sinha.
Great. Thanks so much. Do we have a clicker here as well, too? Or I can click. It's so great to be here. My talk is going to seem so bland after a talk on spices like that, so I'll have to try in my own way to add some spice to my talk here. So, the topic I was really thinking about, so as discussed in that nice intro there, I'm an internal medicine doctor, and I really design health education wellness programs. Thank you. For Silicon Valley companies, because when I started my practice about 10 years ago next to Oracle, I started noticing that despite my traditional Western medical training, I was seeing tremendous amounts of young engineers in their 20s and 30s having their first heart attacks, developing diabetes. And these were like conditions that I learned about in medical school, being in 67-year-old smokers that ate red meat. And I was seeing a lot of them in Indian vegetarians and Chinese people that just immigrated from China. And it really kind of set me on a journey to think that, the traditional approach isn't working. At a lot of these companies, they're given the Mediterranean food pyramid, a talk on, the sort of, the standard dietary guidelines, and clearly they still have a significant number of their population that are suffering from chronic illnesses. So I want to share some of my experiences. We've got a little bit of time here, so I'm going to give you a high level on a lot of this, and I want to leave you time for some questions here as well. But let's dig into some specific ways. I'm glad Kitty introduced the concept of insulin resistance. Does everybody understand insulin resistance? Because that can be very confusing. Do you guys get it? Okay, so I'm going to explain it to you a little bit differently, and it's actually a way that even doctors have learned, because a lot of people don't understand it to the depth that they should, and when they understand it really well, they can make the proper lifestyle changes. So getting back to the question of, is diabetes reversible? I want to put up a patient example right here. I just put the lab results here, but this is what I do in my clinic every week. So this is a 52-year-old software engineer, been pre-diabetic since 2003, developed full-blown diabetes in June 2014, and he was told by his endocrinologist, primary care doctor, that we need to start diabetes medications. So sorry for the small print up here, but A1C is one of the tests that we check, and typically we want that to be less than 5.6. The A1C is reflective of your average sugar for the last few months. So you can see that back in 2010 it was 6.2, 6.1, 6.1, and then it jumped up to 7.5. And really, this guy had tried everything. He went to see the nutritionist on-site at his high-tech company, went through a lot of different avenues, but really with some very simple lifestyle changes, even after having all this for this long, after just 3 months, we dropped him from 7.5 to 5.4, completely eliminated his diabetes within 3 months. So these are the types of cases I see over and over. And as a doctor, it's frustrating because I feel like with traditional training, we're just making people's medication lists longer and longer. And in my practice, my job is to really make it shorter. So I want to talk about some of the ways when we've been able to do that. The first thing is, where's the root cause of insulin resistance coming from? And here in Silicon Valley especially, we see it start in pregnancy. So what happens in pregnancy, in some parts of the Bay Area, including Fremont and Sunnyvale, diabetes during pregnancy is affecting about 45% of moms. That's how common it is, 40 to 45%. And let me talk to you about why this is happening. So first of all, with an unhealthy pregnancy, what typically happens is when the body is producing a lot of insulin. So a lot of unhealthy pregnancies here in Silicon Valley are based on a very sedentary lifestyle. A lot of these are working moms, they're not exercising. Culturally, a lot of people from Indian, Asian background are sedentary and they're eating a lot of carbohydrates, a lot of rice, noodles, and flatbreads. They develop diabetes during pregnancy. Now the problem, the downstream impact of diabetes during pregnancy is when the mom produces extra insulin to bring that blood sugar down, that insulin, what it does is prevents nutrition from getting to the fetus. So typically we see a lot of underweight babies here. And this fetal malnutrition leads to what's called a low birth weight baby. And then when moms see a skinny baby, what does everyone do? The mother-in-law, everybody comes together and they overfeed that child to get them as heavy as possible. And interestingly, a lot of times, my wife's a pediatrician, so she complains about this all the time, but she says that, moms come in, they look at the growth chart, and they look at it almost like an academic curve, and they're like, my child's only in the 50th percentile. We got to get him to the 100th percentile of growth. And it doesn't work like that, because if you quickly accelerate an underweight child and all of a sudden get them to normal weight, you have already set a template for insulin resistance later on. You cannot aggressively overfeed kids, at that early age, or babies, overfeeding to get them that age, because then what happens is their body learns how to store energy in their abdominal fat. They develop insulin resistance, and that sets up the cycle, which then leads to childhood obesity, diabetes, adult obesity, and then that diabetes and insulin resistance gets passed through the genetic material to kids and grandkids and so on. So that's a cycle so a lot of the education that I do is not just adult focused. I bring out OBs, we give pregnancy talks, we give family lectures too to schools and high schools to really see where can we cut off this diabetes train, because it's really getting out of control now all over the world. So jumping into a couple of key concepts from my book, I focus a lot on cholesterol because I think unfortunately, many doctors mismanage cholesterol and many patients don't have a good understanding of how cholesterol works. A couple of high-level things. When we're trying to look for the problem of insulin resistance, a couple of numbers to focus on. Katie mentioned triglyceride. One key number I focus on in my patients is take your triglycerides, on your cholesterol panel, which is a type of cholesterol. Take the HDL, think of H as standing for healthy cholesterol. Take the triglycerides, divide it by the HDL. This is not going to show up on your reports. You've got to do this simple math equation yourself. Triglycerides divided by your HDL, you want that to be less than 3.0. Really critical number, okay? That's a sign, because if that's higher than 3.54, like I see in so many patients, that's a sign that your body's becoming resistant to insulin, which we'll talk about. I'm not going to jump into all these details, but basically, when you look at your LDL cholesterol number on a standard lab, it can be very confusing. Some people with high LDLs are perfectly fine. There's nothing wrong with them. They don't need to go on Lipitor. Other people with an LDL of 100 or even lower are dangerously at risk. And real quickly, one of the things that helps me tell is basically if your triglycerides are high and your LDL is low, that's a warning sign. When triglycerides are high and LDL is low, that's a sign that you've got the dangerous small type B LDL particles. I'm not going to go into a lot of detail on this, but this is something I blog about quite a bit. It's in my cholesterol chapter, but I really teach patients and doctors how to interpret lipid profiles in the right way, because I see too many people that are on statins that don't need to be on it. They could have done easy lifestyle changes to really get rid of their problem. And the other problem too with statins and cholesterol management, in this study at UCLA, they studied almost 140,000 people that were admitted to the hospital with heart disease, and they found that 75% of them had normal LDL cholesterols, and half of them had an LDL of less than 100, which traditional guidelines would say is normal, right? So what's happening in these patients? When your triglycerides are high and you have severe insulin resistance, your LDL becomes dangerous. It looks very normal, but actually it's a sign that your body's at a high risk for heart disease. So that's what I'm sort of talking about. And the problem is when you put patients, many of these patients that come through the door, they're already on Lipitor. They've been given a cholesterol medication. And one of the biggest problems we see is when you put somebody on Lipitor and their numbers miraculously improve in 6 weeks, they're like, hey, I can eat all the cake and pasta and whatever I want. It kind of makes them feel bulletproof, and studies show that people tend to gain an average of 6 to 8 pounds after taking statin medications because they feel like they're bulletproof. But what do the cholesterol drugs do? They don't really lower inflammation effectively. They don't get rid of the belly fat. They don't affect sugar positively. In fact, they can make insulin resistance worse over time. So really, we've got to be very careful about focusing on specific numbers. We have to know how to interpret our numbers in the right way, because the traditional medical system is very focused on if your LDL is high, go on Lipitor. If it's low, you're fine. And that doesn't turn out to be the case. And I'll show you my own lab results at the end so we can make sense of these numbers. Okay? So let's get past this. So again, triglycerides, so if you look at your lab, Cutoffs, typically in most labs it says that your triglyceride should be less than 150, but more updated studies show that we should try to get our triglyceride numbers closer to 100. It's not difficult to do. It sounds very ominous for patients who have been at 300 or 400, but when we make some simple dietary changes, which we'll discuss, we can get them to 100. And 100 is when they really start shedding that inflammatory belly fat. It's when their HDL goes up and their energy levels really start to peak. So on all my patients, I aim to get to that level, and we can do it in most folks. Now here's the scary thing. Again, I told you I lecture at schools with my wife as well too. That triglyceride to HDL ratio is becoming very high in kids and adolescents as well too. So when I see patients in the clinic on Thursdays, I sit right next door to a pediatric endocrinologist, and we're looking at lipid results. I'm looking at 30, 40-year-olds. She's looking at 8, 9-year-olds, and they look remarkably similar. Kids are dealing with the exact same issues that adults are. My wife never learned how to manage lipid disorders during medical training because kids were not supposed to develop cholesterol disorders, but now we're seeing the majority of kids are coming through the door with these issues. And the problem is this study shows that if you have an increased triglyceride to HDL ratio in childhood, it's a significant predictor for arterial stiffness later in life. And when your arteries are stiff, that's when they generate plaque, that's when they rupture from inflammation and cause heart disease. So this is already an early marker, and this is such a common thing that we're seeing in kids, so really important. So if you've got a child, and as a lot of questions come up, a lot of people ask my wife, should all kids be screened for cholesterol? Well, if a direct family member, like a parent, has high cholesterol, absolutely, they should get a baseline lipid test done. So really key for kids to get screened if parents or any first-degree family members, siblings have any issues with cholesterol. Now, the other important thing, why I'm focusing on lipids so much, is often in traditional medicine, we don't diagnose insulin resistance until your blood sugar starts to become abnormal. But the trick about triglycerides and HDL and interpreting your lipids is if you can identify that abnormal lipid profile, that tends to precede the blood sugar abnormalities by up to 10 to 15 years. So when I see, you guys might have heard of the term prediabetes. Have you guys heard of prediabetes? It's when you're right on the brink. But if you've got high triglycerides and low HDL, I call that pre-prediabetes. So I really educate people, capture it at that point. Because then if we make the changes, you really minimize your chances of progressing to prediabetes and diabetes later on. So real key factor there, catch it as early as you can. Don't wait for the glucose to get into that abnormal zone, and then we have the best chance of reversing it. So I call sort of the numbers that I follow the Metabolic Six Pack in my books. These are some of the key numbers that I follow in clinic. They're kind of an iteration of the Metabolic Syndrome criteria, but quite frankly, just to review those really quickly, we look at waist circumference, we look at your triglyceride and HDL level, we look at your blood pressure, which can be a sign of insulin resistance, we look at your blood glucose using a fasting sugar and A1C, and then I actually added on the C-reactive protein, which we'll talk about at the end of the talk. That is a marker of the inflammation Kitty was talking about. Now keep in mind that some people with inflammation will have a completely normal C-reactive protein test. So just because your C-reactive protein is normal, don't think there's no inflammation in your body. You can still have multiple sites of inflammation. But if it is elevated, it's often a very good motivator for us to make lifestyle changes, and often I'll recheck the C-reactive protein later and we see it drop down. So that's very gratifying. So I want to talk about body composition and body fat in a little bit more detail because it really varies amongst different ethnic groups. So I kind of liken the two compartments of fat. Think of a jelly donut, and hopefully it's not going to make you too hungry here. But basically, if you think of the two types of fat, think of the visible outer subcutaneous fat as being the crust, and the more dangerous visceral deep belly fat as being the jelly inside the donut. Now, when you compare different cultures, let's look at the distribution of crust to jelly. So in Caucasians, typically, they've got a fair amount of jelly, but they've also got a fair amount of that visible crust. In African Americans, interestingly, they can have more of that subcutaneous extra visible fat, but they generally do not tend to form as much of the inflammatory jelly. So a lot of African American heart disease and strokes, which tend to be higher in African Americans, are coming from high blood pressure, less from insulin resistance and diabetes. Look at Asians here, okay? So Asians, interestingly, they tend to have much less of that visible crust, but they have a tremendous amount of that hidden inflammatory fat. And that's why in my metabolic syndrome clinic, 20-year-old, 30-year-old heart attack patients, body mass index of 22. They've been told by their doctor they're underweight. They're told by their mom they need to gain weight. But they have so much visceral hidden inflammatory fat because of this genetic distribution that often they go under the radar, they keep eating whatever they want, but they don't realize that they're actually at higher risk than maybe a Caucasian or a European that weighs 50 pounds more than them. So when it comes to goal weights, we have to culturally stratify it, otherwise we're going to miss out on that risk. And that's why I'm so passionate about really looking at people's cultures when I'm identifying their risk. And real quickly, a lot of you might be aware of this, it's been all over the news, but basically when you look at arm and leg fat versus belly fat produces all the ingredients necessary to actually cause chronic disease, heart attacks, and strokes. It stimulates oxidation, inflammation, coagulation. In my book, I give several ways that we can measure it. You can do just waist circumference, waist to hip ratios. I kind of made up this fun thing. I call it the feet test. If you look down and you can't see your toes, we probably have issues, okay? So then we want to lower that visceral fat so then you can see your feet. Obviously, if your feet are like Donald Duck and you've got oversized feet, this is not going to work. So we're assuming you've got normal sized feet. But basically, we're really trying to target waist circumference and bring that down. So whenever I see patients for follow-up, I'm like, are the pants looser? I'm not really concerned about the weight. Are the pants getting looser? Is the waistline coming down? Because that's really the dangerous inflammatory fat. So now let's talk about insulin resistance, maybe at a level that you haven't heard about before. So the problem of insulin resistance, I call it a carbohydrate traffic problem. Okay, so this is an image from my book, and just think of excess carbohydrates as being a car, and there's 3 parking lots in our body. There's the muscle, the liver, and the fat. Okay? And what we naturally want to happen is when we consume extra carbohydrates, we want that carbohydrate car to drive to our muscle parking lot there at the top left. The way it gets inside there, it uses the hormone insulin, which is the parking pass. So when we say somebody's become insulin resistant, what that means is the muscle is no longer responding. It's become resistant to the insulin parking pass. So then what happens is we've got this overflow carb traffic. It's got to go somewhere, so it goes towards fat storage, especially in insulin resistance, visceral abdominal fat storage. The problem is these fat-producing chemicals feed back to the muscle and make it even more insulin resistant, so it perpetuates that cycle. The other place that overflow traffic goes to is to the liver, and the liver does a couple of things. The liver predominantly makes triglycerides, which we talked about, out of the starches, and that's why one of the populations in my clinic that has the highest triglycerides are vegetarian Indians, okay? They're not eating much fat at all. They're not eating meat. It's all coming from flatbreads. It's coming from rice, and it's coming from lentils, excessive amounts of those foods. Or my East Asians are eating a lot of rice and noodles. They're overloading the liver. It's forming triglycerides. The other thing that happens is when the liver becomes overwhelmed, you develop a condition called a fatty liver. Excess fat deposition into the liver. And I want to take a moment to talk about fatty liver. I just did a very detailed blog post on this. Fatty liver is a major crisis. It's linked to insulin resistance. In medical school, I learned that fatty livers happen in alcoholics. Here we're seeing it in young kids, teenagers, and adults. And it's because of this whole system of insulin resistance. And the problem is when the liver becomes clogged with fat, it can't do its essential functions. One of them is to detoxify, to get rid of our environmental toxins. And when you've got a liver full of fat, you can't do that effectively. So again, I tell people our metabolic goal is we want to take that traffic and move it back towards muscle. Okay, that's our key, so our muscle can burn it for energy. We got to get it away from the liver and fat, and that's really essential to really reversing a lot of these issues. So this is kind of a culturally tailored mnemonic, but we can apply this to anyone. Again, since I see so many Asians, I kind of came up with this mnemonic in the book. I call it carbs because they are eating so much. So I tell them we got to cut back on the chapatis, which are flatbreads. If I see Hispanics, we change that to tortillas. They are sometimes consuming a lot of aloo, which is potatoes, rice-based dishes, beans, sugar, etc. So we really work on reducing those amounts and bringing it down to a more reasonable goal. This really helps reduce your insulin resistance pretty dramatically within a very short time. And this is typically what we see because in most people to really overcome insulin resistance, if you're to track like your carbohydrates, your net carbohydrates on a daily basis, if we can get it to, on a daily basis to less than 150, 100 to 150 per day, we can start to reverse that carbohydrate traffic problem that we talked about. But a typical Asian meal or a lot of Western meals, it's 94 to 95 grams in one meal only. And this is like a typical one serving flatbread, lentils, and just some potato. And that's how much, when I fix patients, that's how much they might be eating on a typical day, and that's just one meal. So just understanding how much of these components are in each food and using a little bit of tracking to sort of keep track of this, we can make some dramatic changes in our diet. And one of our key concepts is we use what I call carb copycats. So luckily, before I used to have to teach people how to recipe for how to rice cauliflower, but as you guys know, they sell rice cauliflower now in Trader Joe's in the frozen section, Whole Foods. They all have pre-rice cauliflower. So nobody can give me excuses about not being able to make this. Zucchini, pasta, spaghetti, squash. Make your vegetables look like your carbohydrates. One of the most powerful ways that you can lower insulin inflammation in a very rapid fashion. So a lot of my vegetarians ask me what can they use for protein. So I've done a lot of protein posts in my blog. But basically, the key concept is basically add, whenever we're having any sort of carbohydrates, we want to add vegetable nuts, organic non-GMO soy, paneer, which is the Indian cheese. We can do more dairy, we can do healthy fats, but really changing the composition of these foods can help bring down inflammation and insulin resistance. So saturated fat, I know there's a lot of news that keeps going back and forth on this, and it's very difficult to teach people to really lower saturated fat. Typically, in Asian culture and Indian culture in particular, there's been so much anti-press about ghee, which is clarified butter, and really it's a visceral reaction because here's a little jar of ghee and here's a blocked artery from a heart attack, right? So people automatically equate solid fats with blocking off arteries. But I explain to people is the reason we call this saturated fat is not because it saturates arteries, it's because there's a difference in the chemical bond structure of a saturated versus an unsaturated fat. Saturated fats are saturated with hydrogen ions, and that's why we call it that. It makes it more chemically stable, and it makes it more resistant to inflammation. And in my practice, basically when we use healthy fats in the context of a really whole plant-based diet, we see inflammation markers drop down, we see insulin resistance reverse. There was just you guys must have seen the headlines about coconut oil, right? The American Heart Association just caused a panic about coconut oil, saying it's never been safe, nobody should ever touch coconut oil, which is absolutely ridiculous. And they based it on poorly done studies done in the 1970s. And then unfortunately, the American Heart Association is also supported by the Canola Oil Foundation and Coca-Cola. So there's a lot of conflicts of interest that are happening there. But with each patient, truly, there are some people that have SNPs, single genetic markers that make them saturated fat sensitive. So it's true that coconut oil and saturated fats have to be either eliminated or used in small amounts. I usually don't check those genetic markers. I typically just put patients on a healthy diet and recheck their cholesterol parameters 3 or 4 months later. That's the easiest way to check that. Okay? So here are some of the things that I recommend. So, typically I get asked, so a lot of my Asian patients and Indian patients get a little upset at me. They see me. They're like, rice is part of our diet. You're taking that away from me. But then I provide a little context. So I tell them that, rickshaw pullers. So I used to go to India every other summer during my childhood. And rickshaw pullers actually found this statistic. On average, they walk and run about 40,000 steps a day. Okay? And my average engineer, because I actually measure their walking steps like a vital sign, about 2,000 steps on a good day to 2,500. So they're 20 times less active, and they expect that they can eat the same amount of rice as their Indian ancestors. The second thing is obviously when you're carting around people, strong leg and core, especially with the increase in obesity, they're carting around even heavier loads now. And then of course our Asian Indians, we're sitting at the computer all day, legs and core are very weak. Normal vitamin D. So vitamin D is a powerful anti-inflammatory. It also helps with insulin resistance. If you're out, relatively shirtless in the sun all day, you're going to have normal vitamin D levels. But we see significant, rampant, severe vitamin D deficiency here in Silicon Valley, and that can make insulin resistance and inflammation worse. So in this context, yes, this guy can absolutely have rice in moderate to high amounts because his muscles have deserved that sort of energy load. But in this situation, it's not okay. So can we, we're not going to tell our engineers to become rickshaw pullers, pulling rickshaws down El Camino, but we can try to basically modify some of their lifestyle habits to mimic some of this. So here are some of the tricks that I use in clinic. First thing, hopefully most of us are wearing some sort of activity monitor, but the key thing with activity monitors is I tell people, many of my patients try to get all their steps in the morning or evening, but I tell them really try to distribute their walking steps throughout the day because that keeps you burning sugar on a more regular basis. The newer generation Fitbits, the Apple Watches will give you hourly step counts, but if you don't have that, I just tell people try to get at least 4,000 steps by 1 p.m. That kind of ensures that we're getting regular activity that's distributed. That keeps you burning glucose, and it keeps inflammation levels lower throughout the day as well. Interval training is a fantastic way to get your muscles more insulin sensitive. If you're not familiar with it, any sort of routine that has you doing something very fast for 20 or 30 seconds and you stop or slow down for 10 or 15 seconds, that will accelerate fat burning and help insulin resistant cells become more sensitive. I prescribe apps like the Tabata app, or I love the Seconds app. Even in folks that can't sprint and go high intensity, studies have shown that even if you walk fast and walk slow without breaking a sweat, even fast walking, slow walking for 20 minutes is equivalent to about 45 minutes of walking at a steady state. It lowers sugar very effectively. So always try to work out or walk or exercise in intervals whenever possible. So resistance training, I remember one summer I went to India and there was a monsoon flood there, and these guys were still pulling people. They pulled our whole family to get to a wedding or cross water here. So talk about the ultimate form of resistance training. But basically, what I try to do is I really try to get a lot of my patients to really connect to some part of their ancestry, some family members. We used to sit around, my 80-year-old grandmother used to sit in this position and make tea and breakfast for everyone. So we try to get people to really get engaged with these sorts of traditional maneuvers. We really try to increase leg strength. The way I get them to do this is I'll have them, again, I like to prescribe apps over medications, and these are the apps I like. Runtastic makes some great accelerometer apps. So typically I have them download an app called Runtastic Squats. So it's got an accelerometer on your phone, so while you're doing squats, it actually automatically counts how many squats you're doing. So I literally, when patients come back, I'm like, I want to see your data. How many apps have you done since I last? So how many squats have you done? And the nice thing is their leg strength goes up, and their blood glucose and their triglycerides get better as well too. The push-up app, pull-up apps, all these are great ways to keep people motivated on schedule. And yeah, if you see me as a patient, I'm going to be keeping track of this stuff. It's really key. All right, so I'm not going to go into detail, but I do a chapter on PCOS. PCOS is a really common insulin-resistant condition that's happening in young girls and teenagers, something to just be really aware of, because many of these cases can evolve into gestational diabetes during pregnancy. It can lead to infertility. With PCOS that these teenage girls have, the diabetes risk is 7 times greater and also increased heart disease risk. So this is something many women that are seeing me in their adulthood, they had this condition before, but they weren't aware of it. And if it really was diagnosed and we implemented lifestyle changes then, they could have prevented a lot of these complications. Okay? So this is another lecture we've been giving here in Silicon Valley, and I call it the Is Your Child a Startup? And the reason I sort of came up with this topic is because working with pediatricians in my practice, we are seeing so much metabolic disorders, triglycerides, overweight, obesity, depression, anxiety, all of these. So now we're really trying to educate families about how our typical way of raising kids here in Silicon Valley is leading to chronic disease and illness. So typically we'll take people through a typical daily day in the life of a busy family. So getting up early, trying to get to sports practice. School hours are already so fatiguing, and a lot of these kids are not really eating a proper breakfast. They come home from school, and a lot of parents just forget the fact that school is a very draining activity, to be in classes from 8 to 3, but they're shuttled off to academic enrichment, sports, music. They have no chill time, or hardly any time for a healthy snack. 6 to 8 p.m., major dinner time chaos. Hardly any family dinners, getting unhealthy meals, ordering in. Then after that, there's more homework, extra academic work, music practice, etc. And weekends can be just as chaotic. Does this sound familiar to anybody? Anybody live in this? Right? No, not here in Silicon Valley. But so we really try to teach people that these are really some of the behaviors and habits. And I know a lot of it we can't avoid, for teenagers, college admissions, all of this, but we need to create some space. Can we get in a healthy meal here? Can we create some rest? Can we do some things that are really going to enhance? Because the thing is, if you don't teach kids how to find wellness spaces during a busy day, they become workaholic adults later on. And those workaholic adults cannot slow down. They've been conditioned to be like that from childhood, and then we end up seeing these chronic conditions. One thing I lecture to companies is this condition that I call entrepreneur syndrome. I'm seeing a growing number of 30-year-old execs coming in. They perfect body composition, single-digit body fat, cholesterol numbers normal, everything is fine, and they have a heart attack at age 30, 32. I've seen this in at least 20 high-level executives. It's all coming from this sort of pace. They don't know how to slow down. They stay up late at night. They're high performers, so they don't change at all, and that causes rampant inflammation in the body that can lead to first-generation cancer or heart disease. And after seeing this over and over, it really helped me slow down. Not slowing down my speaking, as you can tell. I got to work on that, but I try to slow down in other parts of my life, right? So that's overscheduling. So this I wanted to just highlight really quickly. Again, I know it's tough to see, but this is a patient of mine that had metabolic syndrome, so all the abnormal numbers here. But I want to focus just on one thing here. He had this inflammation test called the C-reactive protein, which we like to see this number less than 3, ideally less than 1. And he was at 10.6 in March 2013, so really high. He had the high triglycerides, low HDL. So pop quiz, triglyceride to HDL ratio should be less than? Oh, wonderful, right. So he was at basically 4.7. He had the dangerous type B cholesterol. So then he made some significant changes. So we shifted him from B to A. Asian patients like getting A's over B's, so they're very happy when they go from B to A. So he went from a B to A, 4.7 to 1.8 on the ratio. But his C-reactive protein had dropped, but it wasn't completely normal, 3.6. So then I was thinking, how can we really get this down? And then he admitted to me at this time, he didn't tell me before, that stress was a major factor in his life. So we said, listen, you can keep the diet the same. Let's just work on doing some meditative practices, some mindfulness. And he worked on that for a few months. So from July to October, rechecked his inflammation number, 3.6 to 0.6. Perfect, right? Just through that. And there's multiple studies that show the effects of mindfulness on inflammation, and I see this over and over. So a lot of people that might have that initial drop, they may not normalize inflammation until they adopt some sort of mindfulness practices. So this is really a biochemical, biochemical piece of evidence beyond the power of these practices. So how do we manage stress? I know there's a lot of things on mindfulness. There's a lot of different techniques. Again, for a lot of my techies, it may not go down that route. I do prescribe apps again. So I like using this app to teach people how to do pranayama, deep style breathing. So actually the name of the app is Pranayama. It's by a company called Sagara. And it's a great app that teaches kids and families how to breathe. It uses breath cueing sort of soundtracks. My kids love using this. Otherwise, you can also do other tools. You can use resting heart rate or a measurement called heart rate variability, which you might have heard of, which actually checks how your parasympathetic and sympathetic system are interacting. So a simple tool I start off with is an app called Stress Doctor. It teaches you to breathe in a way that will keep the heart rate variability in check. If you want to use more advanced devices that are more accurate, there's the M-Wave heart math device, but many of my patients said don't invest in that. I have them just use this $4 or $5 app to teach them how to breathe properly. It can be a very powerful tool. Okay, so now I'm going to show you my lipid numbers and sort of how I got sort of motivated to do all this. But back in 2009, you can see that my triglycerides were 314, my HDL level was 28, and this is when I was exercising 5 days a week and following all the nutrition guidelines out there. Look at my LDL, right? So I told you doctors tend to focus on LDL. My LDL is 85. So a standard doctor would look at that and say, hey, Ron, you know, your triglycerides and HDL, they're bad, but at least your LDL is okay. But I taught you that look at my ratio, right? 11.2. When your ratio is high, it can falsely depress your LDL. So many doctors look at patients like me, who I was back then, and say, listen, you're fine, your LDL is okay, just exercise a little bit more. I may not have survived that if I actually, adhered to that. So then I sort of followed the dietary principles that I talked about, and you can see that very quickly I shifted the triglyceride HDL ratio down to 1.9. We shifted from a B to A. And I just put basically a general point that this is not just my data, it's my family's data, because my impact is going to have an impact on the family if I develop a health condition. I need to model that behavior for my kids so their kids do well. It really is a shared responsibility to make sure that we can bring these numbers down to normal, and this is really the key. We want to really implement this for the entire family. And this is how I sort of stratify, because we don't want busy families to cook 3 different meals at home. So I tell them, for example, if we have an at-risk insulin-resistant family member, if we're having pasta night, maybe that at-risk person has a carb copycat. Zucchini noodles, shirataki noodles, spaghetti squash. You've got an active family member, like my kids playing basketball. They can have pasta, maybe whole wheat, fine. And the entire family will benefit from the salad, the fresh sauce that's been made, and the fruit, the herbs and spices that you heard about from Kitty. If it's Indian night, again, an at-risk person, do more cauliflower rice, maybe coconut flour chapatis. A healthier member that's been physically active, rice and quinoa can be fine. And use the same vegetable curry, a good base meat, seafood, etc. in a salad. Mexican nights, more burrito bowls and lettuce wraps for the at-risk family member. Tortillas might be fine for a family member or somebody who does not have any signs of insulin resistance. So you can see that if we can switch out this, the starch part of it and then really modify the other parts, keep those consistent, this is what we really recommend for families, and they do really well with this. And the good news is when even our high-risk folks become insulin sensitive, they can actually start reintroducing these foods back into their diet. Now their muscles are more insulin sensitive, they're more physically active, active, so they can have more quinoa, they can have a little bit more rice. So I love being able to reintroduce that because now they treat these foods as a real treat. They're not just eating abundant amounts of these starches and suffering from the impact of insulin resistance. Okay, so in the back of my book, I've got a lot of recipes and food substitutions. I put all the normal value tables here, a lot of case studies and recommended apps and online resources. I blog pretty actively at this site. I'm developing some online programs that are about to go live. And I'm also partnering with some companies to develop some foods based on my principles. So gluten-free, low-carb, flatbreads, chapatis, and all that stuff. So we're hoping to really bring a lot of this to our families that are too busy to make these things on their own. Okay, and lastly, I'm doing a retreat at the end of July with my dietitian. So if you guys want to get away for 2 to 3 days into the woods, check out that site, and I'll be happy to entertain you guys then. Okay? So we'll open up to questions. I know it went kind of fast, but I know it's been a long night for you guys, and I wanted to make sure you guys had a chance to ask some questions. Thank you. Thanks.
Okay, questions? Questions?
You talked about low C-reactive protein. What about homocysteine?
You're right. So homocysteine basically, elevated homocysteine levels. So basically, if an individual has a problem metabolizing folate, which is a B-type vitamin, they can get an elevation in homocysteine. And homocysteine elevations have been associated with elevated cardiovascular and stroke risk. So there is a connection between those two. Interestingly, there's no good, well-done studies that show that lowering homocysteine actually lowers heart disease and stroke risk. But I still think it is important to pick up on in certain people because if they, for example, have deficient folate or they have a genetic marker, a metabolic change that will not allow them to metabolize folate, they need to be supplemented adequately to reduce that. So I think it's important. I would admit it's not a first-line screen that I check, but in some of my cardiovascular patients, if we do an extended panel, we will look at homocysteine levels. So, yeah. There are, so methylated folate versus regular folate. So if you have a problem methylating that gene, then you do have to take the methylated version of folate, which will be better absorbed. So, yeah.
Is there a problem with too low triglyceride?
Is there a problem with triglycerides that are too low? In general, I'll tell you that we don't want cholesterol levels to be too low. So for example, with triglycerides, I rarely see that issue. So even if people, I rarely see triglycerides below like 50, 60, anything like that. So I'd say usually it's not a problem. LDL cholesterol, sometimes we see them drop too low because patients are on very high dose statins. And that can be a problem. As we know, our brains, our cells, we need a certain amount of minimal cholesterol for appropriate functioning. And unfortunately, a lot of medical guidelines keep saying the lower the cholesterol, the better, but that's clearly not the case. It can cause a lot of adverse effects. So, yeah, thank you.
Do you agree with Dr. Grossman that so many adults are in some spectrum of insulin resistance, even if they don't have any clinical issues?
I would say that based on my experience and current lifestyle, I would say that every individual has some degree of insulin resistance until proven otherwise. So I really do think so. That's how rampant it actually has become. And like I said, we talked about some early markers, but there are things that are happening at the cellular level that are probably putting people at risk already. So yeah, I agree with that concept, absolutely.
Could you take a couple of minutes and talk a little bit about your personal journey into the kind of a different kind of medicine than maybe how you were trained in medical school?
Sure, that disconnects. So, you know, the thing is with the traditional medical system, we're often told to stick to very specific protocols and guidelines. And unfortunately, those guidelines are very generic, right? So like I said, if your LDL is at this level, you go on this dose of medication. And it doesn't really look at personal risk factors, culture, and other ethnographic information. And that's the thing that's missing. You're cramming in so much information. Also during medical training, you spend a total of maybe 3 to 4 weeks on nutrition. And of that, it's mostly nutrition biochemistry. You don't learn about how to really impact people to lose weight and reverse insulin resistance. So all of that is really a huge weakness in the system. For me, this journey probably wouldn't have happened until I developed metabolic syndrome and those issues. And I realized that the approach that I was preaching to patients was absolutely not working in myself. And that's when I was like, I can't give people advice that I'm following and is not working. So then I had to step outside of the medical system, unfortunately, and sort of create my own path. And the rewarding thing is, you know, there's been a lot of times where I've been tempted to sort of step away and create my own practice and sort of do my own thing. But the nice thing is I've been able to do this within Palo Medical Foundation, Sutter Health, which is one of the largest medical groups in the entire country. And now we're influencing doctors. I have cardiologists referring patients to me to get patients off statins. So that's, I think, the real gratifying part. You don't have to pay extra money to see me in a private practice. A lot of our doctors are practicing the same way, and hopefully that's going to be the future of medicine for us, because the current system's not the right way to go. So thank you. Yeah.
I noticed the absence of any mention of hormones like thyroid.
Yeah.
There's some of these foods are really thyroid suppressive, and if you don't
Absolutely.
have enough protein in the diet, which they seem to have a very low protein, the liver is not going to be very efficient converting T4 into T3.
Right.
And that often causes high cholesterol because the body protective is
Good point, yeah. So thyroid metabolism definitely is a separate, very important topic, because we're saying, and a lot of the thyroid problems that we're seeing in our clinic are because of that autoimmune phenomenon. Our body's inflammatory system attacking our thyroid, and that's become a pervasive problem in many of our patients. And again, a lot of the anti-inflammatory strategies we talk about can help remedy that, but you're right, the protein and the other macronutrients have to be in the right balance for us to convert properly, because there is a small, I'd still say it's a smaller subset, but some of these persistent lipid disorders often can be tracked to abnormal thyroid metabolism. So we have to make sure we optimize thyroid function. So thanks for bringing that up. That is important.
Okay.
Great. Thank you, guys.
Yeah.